This video discussion in the Clinical Toxicology series is about simple asphyxiants and pulmonary irritants, corresponding to Goldfrank's chapter 121. The learning objectives for this session are that you'll be able to explain the difference in mechanisms between simple asphyxiants and pulmonary irritants, and be able to outline treatment plans for patients exposed to these agents. Starting off with asphyxiants. Although the word asphyxia is from the Greek meaning without a pulse, in modern medical parlance and in common use, it refers to anything causing a state of oxygen deprivation. And if the asphyxia goes on long enough, sure, you'll become pulseless then too. One can asphyxiate from errors in the mechanics or neural control of breathing. Another possibility is that there just isn't enough oxygen present in the inspired air, and that's what's happening in the case of the simple asphyxiants. The next possibility leading to asphyxia is if there are problems with the diffusion of oxygen from the air into the blood, due to issues in the lungs. And the final possibility is that plenty of oxygen is getting into the body, but the mitochondria have been poisoned and can't use it. This is called chemical asphyxia, and occurs with several mitochondrial poisons, including carbon monoxide, cyanide, and hydrogen sulfide, which are covered in other videos in this series. Simple asphyxiants are called simple because they simply displace oxygen by taking up a high percentage of the volume of the ambient air. Normally, we breathe in an atmosphere of about 21% oxygen, and nearly all the rest is nitrogen. However, if any other gas is found in high enough concentrations that the oxygen level dips, you'll start to see signs of hypoxia. And the table here shows how the signs and symptoms get worse and worse the lower the ambient oxygen level is. If the percent oxygen is down to the single digits, people can pass out and die quickly. Some simple asphyxiants are occupational hazards, such as encountering methane while mining. This is the reason for the saying about the canary in the coal mine, since small birds having a higher basal metabolic rate would be more susceptible to hypoxic environments. The textbook chapter suggests a few possible scenarios of simple asphyxiant toxicity, but the one that I think is most likely to be encountered is a person entering a walk-in refrigerator or freezer where dry ice has been sublimating, filling the chamber with CO2. Treatment is straightforward. You've got to get the victim out of the exposure area, hopefully without succumbing to hypoxia yourself. So in some situations, this might require protective gear or a hazmat team. And then provide oxygen to the patient, and any other resuscitative measures as needed. Now, strictly speaking, carbon dioxide is not a true simple asphyxiant, since increased CO2 levels in the body have additional physiologic effects, so oxygen displacement is not the only thing going on, but it's close enough. The main thing about simple asphyxiants is that exposure to the gas doesn't cause any symptoms. All the symptoms are caused by the lack of oxygen. The pulmonary irritants, on the other hand, are irritating. These are gases that dissolve into water in mucous membranes and in the lung, and at least initially cause irritant effects, although they may progress depending on the exposure concentration and duration to cause even worse downstream toxicity. There are very many pulmonary irritants, including chlorine, ammonia, ozone, NO2, nitrogen dioxide, etc., etc. This slide is just one example, the example of chlorine. The Cl2 gas will dissolve into the water of the mucus lining the respiratory tract, where it reacts with the water and releases various acids which start to damage the epithelium. And various reactive oxygen species are also generated, such as superoxide and peroxynitrite, causing further injury. And it was for this reason, because it can cause this inhalational injury, that chlorine was the first kind of gas used in mass chemical warfare in World War I. And here I'm using chlorine again, comparing it to chloramine gas to illustrate another important point. The more water-soluble the gas, the faster it will produce symptoms, giving it more favorable warning properties. We see here from the structures that chloramine is polar, while chlorine is nonpolar, so chloramine is more water-soluble, and therefore causes faster irritant effects to the respiratory and upper aerodigestive mucous membranes. And if it's more irritating, you feel the need to run away from the exposure, if that's possible. But with less water-soluble gas, you'll be breathing it in for longer before it starts to make your eyes smart, and nose, mouth, and throat burn, and cause you to choke and cough before you're hopefully able to run away. Thus, if we know something about the water solubility of the pulmonary irritant, this might help guide how long we'll want to observe the patient who is minimally affected before saying they're stable for discharge. And it also means that if everything else were equal, we might be more worried about a victim exposed to a less water-soluble gas, because they might have been breathing in a lot more of it before they became so symptomatic that they then ran away, assuming they had any control over their escape. The treatment of pulmonary irritant exposure is very similar to that used for reactive airway disease, such as asthma. Some patients may just need to be removed from exposure if they are asymptomatic or minimally symptomatic. For more serious cases, you treat with supplemental oxygen, give nebulized beta agonists, especially if they're wheezing, and corticosteroids. From an earlier slide, you'll remember that some of the pulmonary irritants will elaborate acids when they dissolve in water. So there's some thought that nebulized sodium bicarbonate might be helpful to neutralize those acids. This is an interesting theory, and it probably won't hurt, but it is not a proven effective therapy. Another potential occupational inhalational exposure to mention is metal fume fever. This can occur several hours after exposure to metal fumes, as may occur with welding or other kinds of metalwork. This causes a self-limited flu-like illness with fever, chills, cough, and body aches. Polymer fume inhalation causes a similar syndrome to metal fume fever, but in this case it's due to inhalation of the pyrolyzed products of fluorinated polymers, as may occur if you accidentally burn a Teflon-coated pan. So that's it for this sampler of toxicity from inhaled gases and fumes that don't have much, if any, specific therapies to remember. I'll be seeing you around.